Good morning to all. Today's topic is on gingivitis, stages and clinical features. Learning outcomes are classify gingivitis, explain the various stages of gingivitis, describe the clinical features of gingivitis, list the causes for melanin pigmentations, compare the clinical and histopathological appearance of gingivitis. Introduction. So the gingival health should be defined as a state which is free from inflammation. So when there is inflammation of gingiva, it is termed as gingivitis. The clinical signs and symptoms of inflammation, which are confined only to free and attached gingiva, when it is not involving the mucogingival junction, they are called gingivitis. Coming to gingivitis classification in 2017 AP classification, it is included either under due to dental biofilm induced or non-dental biofilm induced. So under dental biofilm induced, it can be either due to non-periodontitis case and also it can occur in stable periodontitis. So let me explain you in details. So this is the first case, that is in non-periodontitis case. So there is no periodontitis, only gingivitis. So in this case, you can see that it can be either localized or generalized. So there won't be any clinical attachment loss. Okay, there won't be any loss of bone, any loss of supporting structures. So but the radiographic bone loss, you cannot see any radiographic bone loss also, no loss of bone, and the probing pocket depth also will be normal, that is minimal, that is less than 3 mm. And bleeding on probing, it can be either under localized category, that is 10 to 30 percentage, or generalized greater than 30 percentage. So this is the case that is occurring in non-periodontitis, the normal gingivitis in intact periodontium. So when we come to stable periodontitis, means there will be reduced periodontium, there is loss of attachment, clinical attachment, and there will be radiographic bone loss also, but the probing pocket depth will be minimal, that is 2 to 3 mm. Bleeding on probing will be there, localized category, that is either 10 to 30 percentage or greater than 30 percentage. So in this case, you can see that there will be a recession due to some other reasons, not as a sequelae of gingivitis. You can see that due to cervical abrasion or due to crown lengthening or any other non-related factors can be the reason for this attachment loss. So in this case, it is not regarded as periodontitis, it is regarded as gingivitis based on the gingival features, that is the bleeding on probing. So next, coming to the gingival disease, that is non-dental biofilm induced. So it is induced by non-plaque induced pathology lesions. Either it can be due to genetic or developmental disorders or some specific infections, that is it can be due to bacterial, viral or fungal. So these lesions will be limited to the gingival tissues. Although these lesions are not directly caused by the plaque, their clinical cause may be impacted by plaque accumulation and subsequent gingival inflammation. Coming to the classification, so this gingivitis can be classified according to the cause of disease or due to the distribution. So first, coming to the cause of disease, it can be acute, recurrent or chronic gingivitis. So first, coming to the acute gingivitis. Acute gingivitis means it is a sudden onset, short duration. It can be painful. So a less severe form of acute condition that can be is called a subacute. Coming to the recurrent gingivitis, that is a gingivitis which appears even after the elimination by the treatment, and chronic gingivitis, that is low in onset, long duration, and is painless also, very dull. Like if it is present, it will be very dull. So inflammation will be resolved in some areas, will be persisting in some areas, and some areas will be normal also. So coming to the classification according to the distribution, as you know, localized, it can be localized or generalized. That is, if the few teeth are involved, that is less than 30% is involved, it is localized. And if it is involving the entire mouth, it can be called as generalized also. So according to the areas also, it has been divided, that it can be marginal, papillary or diffuse. That can be either localized marginal, localized diffuse or localized papillary. It can be generalized marginal, generalized diffuse. So when it is called as localized papillary, that is involving the internal papilla of some of the teeth. And localized marginal means which will be involving papilla as well as marginal. What is diffuse means it will be extending from the margin to the attached gingiva also. That is diffuse type of gingivitis. Localized when it is involved in some few teeth. So then coming to the generalized marginal and generalized diffuse, generalized marginal, that is which involves the gingival margins of all teeth, almost all teeth. So in this case, general papilla will be more affected because it is the firstly the papilla will be affected and then it will be extended to the marginal areas. Generalized diffuse means which involves the entire gingiva, alveolar mucosa and attached gingiva are affected. It may be usually be caused by systemic conditions. Coming to the stages of gingivitis, which is very important, Page and Schroeder summarized widely scattered studies on the pathogenesis of periodontitis. So he has come up with a with the stages of this gingivitis. So mainly there are three stages. So that is the initial lesion, early lesion, established lesion. So it is being given in a tabular column. So first one, that is the initial lesion, that is a stage 1, okay, which appears in 2 to 4 days. And in blood vessel changes, so we are discussing here both the clinical findings as well as the histopathological findings also. So under blood vessel there will be vascular dilatation and vasculitis, and the epithelium, the initial epithelium and cellular epithelium will be infiltrated by polymorphonuclear neutrophils, and the predominant immune cells will be PMNS. The collagen will be perivascular loss will be there, and the clinical findings will be gingival fluid flow. So gingival fluid flow or bleeding on probing is the most earliest sign of gingivitis. So this gingival fluid flow cannot be seen in clinically. So this is called as subclinical gingivitis. So the initial lesion is either otherwise called as subclinical gingivitis. Then coming to early lesion, which occurs within the time period of 4 to 7 days. So coming to the vascularity, that is, there will be vascular proliferation. And this junction and circular epithelium, there will be infiltrated by PMNS, and stage 1 retipex formation and more will be atrophic areas will be more in case of early lesion, and the predominant immune cells are lymphocytes, and there will be increased loss of collagen, and the clinical findings will be erythema, that is the redness of gingiva, and bleeding on probing can be seen. Coming to the established lesion, that is the chronic gingivitis, established lesion, that is a third stage, which occurs in 14 to 21 days. So same as stage 2, that is there will be vascular proliferation, so which leads to venous stasis, that is the blood stasis. So and junction and circular epithelium will be same in a retipex atrophic formation, that it will be in more advanced stage, and predominant cells will be plasma cells, and there will be continued loss of collagen, and the clinical findings will be there will be changes in everything, that is a change in size, color, texture, consistency. So there will be more established lesion, you can see the color will be bluish in color due to venous stasis, and size will be changed, consistency will be changed, surface texture will be changed, contour, everything will be changed in this case. So there is one more stage, that is advanced lesion of gingivitis. Advanced lesion of gingivitis means there will be destruction of bone. So alveolar bone destruction, ligament attachment loss is there. So this is termed as periodontitis. That is the fourth stage, that is the advanced lesion. Coming to clinical examination, as you all know, there is a first stage initial lesion is subclinical feature, that is a gingival fluid flow, cannot be seen clinically much. So the two earlier signs of gingival inflammation are increased gingival clavicular fluid, bleeding on probing. So there is a bleeding. These are the two earlier signs of gingival inflammation. And then after that there will be change in color, size, contour, consistency, surface texture, position, ease of bleeding and pain, and separation. Coming to the details of each clinical feature, first one, gingival bleeding on probing. It is widely used to measure disease prevalence and progression, to measure outcomes of treatment, and to motivate patients with their home care. Bleeding on probing varies in severity, duration, and ease with which it is probed, and is also related to the severity of inflammation. This can easily be detected by periodontal probe, and this detects the early diagnosis and prevention of more advanced gingivitis. So even the presence of plaque for only 2 days can initiate bleeding on probing, whereas once it is established, it needs more advanced continued plaque control treatment to eliminate the gingival bleeding. Even though gingival bleeding on probing may not be a good diagnostic indicator for clinical attachment loss, its absence is an excellent negative predictor of future attachment loss. Why? Because gingival bleeding on probing, which indicates the periodontal disease activity, so its absence is an excellent predictor of future attachment loss. That is, therefore, the absence of gingival bleeding is desirable and implies a lower risk of future clinical attachment loss. Coming to gingival bleeding, it can be of different factors, local factors and systemic factors. First, we are dealing with the local factors. It can be of two types. There is chronic and recurrent bleeding and acute bleeding. So the first one is chronic and recurrent bleeding. As the name indicates, it is due to the chronic cause, or by recurrent bleeding is due to the frequent provocation by any factors. So the severity of bleeding and ease of its provocation depends on the intensity of inflammation. So when there is gingivitis, so there will be bleeding on probing. So this can be provoked by mechanical trauma like toothbrushing, toothpicks or food impaction, or by biting into solid food such as apples. So after the vessels are damaged and ruptured, interrelated mechanisms induce hemostasis. Histopathological changes can be described as dilatation and engorgement of the capillaries, thinning or ulceration of the circular epithelium. So coming to the acute bleeding, so that can be due to acute causes like injury that occurs spontaneously in acute gingival disease like ANAC, a laceration of gingiva by toothbrush bristles due to vigorous toothbrushing, sharp pieces of hard food, or it can be due to gingival burns from hot foods of animals. Then coming to the gingival bleeding associated with systemic changes, there can be different systemic factors that lead to gingival bleeding. So this gingival hemorrhage can occur spontaneously or due to any other irritation that will be excessive and it will be difficult to control. So this tendency is mainly due to failure of one or more of the hemostatic mechanisms. So coming to the disorders that which cause abnormal bleeding are vascular abnormalities, hypoproteinemia, other coagulation defects, deficient platelet thromboplastin factor, or any other drugs, salicylase and anticoagulants, that is anti-clotting factors, so such as dicomerol and heparin. Coming to the color changes in the gingiva, color of the gingiva is determined by several factors, include the number and size of the blood vessels, epithelial thickness, quantity of canalization, and number of pigmental cells in the epithelium. So when there is inflammation, the gingiva becomes more red, and where there will be increase in vascularization and degree of canalization will be reduced. And the color becomes pale when the vascularization is reduced or epithelial keratinization increases. So this mostly you can see that vascularization will be reduced in case of patients with anemia and also in females the with menstruation. The gingiva becomes bluish because of venous stasis. You can see in case of the chronic gingivitis, that is the third stage of gingivitis, and the changes start in the interdental papilla and the gingival, and then to the gingival margin, and then it will be spread to the attached gingiva. Color changes can be seen in acute diseases also. The color changes can be marginal, diffuse, or patch-like depending on the acute condition. So, color changes in acute gingival inflammation differ both in nature and the distribution. So, that is what we told that it can be marginal, diffuse, or patch-like. So, you can see that mostly it will be like a whitish gray color for the acute diseases, acute that is in case of acute in necrotizing ulcerative gingivitis it will be marginal. In herpetic gingival stomatitis it will be diffused, And in acute reactions to chemical reaction will be can be patch-like or diffuse. Color changes vary with the intensity of inflammation. So in acute infectious disease, it can be either marginal, diffuse or patch-like. It will be mostly like a whitish gray or gray pink color. Coming to the metallic pigmentation, so heavy metals like bismuth, arsenic, mercury, lead may discolor the gingiva or oral mucosa. So usually this provides a black or a bluish line in the gingiva that follows the contour of the margin. So this pigmentation can be isolated black blotches involving the interdental, marginal and attached gingiva. Gingival pigmentation from systemically absorbed metals. It's mainly due to this absorption, perivascular precipitation of metallic sulfates in the subepithelial connective tissue. So this gingival pigmentation is actually not due to the result of this excessive intake of the metals or any toxicity. It occurs in areas of inflammation. So these areas will be there will be increased permeability of vessels and which permits the seepage of metal into the surrounding tissue. So, in addition to inflamed gingiva, mucosal areas that are irritated by biting or abnormal chewing also can take up this pigmentation. Usually, it happens in areas of lips, cheek, and the lateral border of tongue. So, that's about the metallic pigmentation. So, this leads to a bluish or blackish hue for the gingiva that is mainly due to the inflammation in which increased permeability of irritated blood vessels which permits the seepage of the metal into the surrounding. So coming to the color changes associated with systemic factors. So systemic diseases may cause changes in the oral mucosa including gingiva also. So there can be endogenous factors and exogenous factors for this color changes. There is endogenous can be due to melanin, bilirubin or iron. You can see that melanin pigmentation will be more, that is a normal physiology change that is mostly found in highly pigmented ethnic groups. And also there's some diseases can also cause this melanin pigmentation. There is Addison's disease, Peutz-Jeghers syndrome and Eiweiß syndrome. So coming to the bile pigments, there is increase in bilirubin can be seen in jaundice. So then the oral mucosa may acquire a yellowish color, and the deposition of iron in case of hemochromatosis may produce a bluish gray pigmentation of the oral mucosa. And moreover that the several endocrine and metabolic disturbances such as diabetes in pregnancy may also result in color changes. Then coming to exogenous factors, that is the factors from external sources that can be due to atmospheric irritants such as coal or metal or some food coloring agents or from the tobacco chewing also can increase in melanin pigmentation of oral mucosa, and also some like accidental amalgam implantation in the mucosa can also produce localized bluish black areas of pigmentation. So coming to the next clinical feature, that is there will be changes in the consistency of gingiva. So that is in normal case it will be firm and resilient, the consistency, but in case of gingivitis there can be change in firm and resilient. There is more like soft and edematous. So you can see both chronic and acute type of inflammation and the changes in the consistency. That in chronic gingivitis, you can see either a destructive type or a reparative type, or it can coexist also. So that in case of destructive, there will be more edematous. It will in picture you can see that it will be more like soft and edematous can be the consistency. But in case of reparative, sometimes there will be reparative changes due to some oral hygiene in some measures. So there can be reparative stage coexist with that, so that the outside we can see that some amount of thickened, that is a fibrotic, but actually the edematous wall will be hidden by the reparative stage. So that is what in case of when both coexist. So the consistency of gingiva is determined by their relative predominance. So these are the clinical and histopathological changes in gingival consistency. You can see that in case of like gingivitis, the first early lesion and all, you can see that soggy puffiness. So the reason for it is that is infiltration by the fluid and cells of the inflammatory exudate, and there can be marked softness and friability with ready fragmentation on expiration with probe and pinpoint surface areas of redness and desquamation. So that is the mainly due to the degeneration of connective tissue and epithelium. Then firm leathery consistency, as I told before, it is because of the fibrosis and epithelial proliferation with a long-standing chronic inflammation. The acute forms can be diffuse puffiness, that is the acute inflammatory region edema due to the edema and fatty infiltration in xanthomatosis. Sloughing with grayish flake-like particles of debris adhering to eroded surface. So it is mainly due to the pseudomembrane composed of bacteria. And then the vesicle formation, that is due to the intercellular and intracellular edema or degeneration of nucleus and cytoplasm and the rupture of cell wall. So next, coming to the surface texture of gingiva. So when we coming to the normal feature, that is the stippling will be present. So for that you have to dry the gingiva. You can see that this is the orange peel appearance of the gingiva. So it is called as stippling. So actually, what is this stippling? So this is looks like orange peel, but what is actually it is? So it is an external reflection of the underlying connective tissue projections into the overlying epithelium. We have already studied the structures of epithelium and the connective tissue. There will be papillary projections. So that is the main reason for this. So that is the connective tissue projections into the overlying epithelium. It is seen as this stippling. So the presence of stippling in attached gingiva is indicative of gingival health, and this surface structure is usually lost when it is edematous. So when it is disease condition, you cannot see this clear-cut stippling. So there will be loss of stippling in an early sign of gingivitis. So there can be absent also. It is not necessary that you should see for in all patients. So in some patients it will be absent also. So you can write it as absence of stippling. But here in case of gingivitis, there will be loss of stippling when it is involving the attached gingiva. In chronic inflammation, the surface is either smooth and shiny or nodular, depending on whether the dominant changes are exudative or fibrotic. Smooth surface texture is produced by the epithelial atrophy. Uh, in atrophy gingivitis, peeling of the surface occurs in chronic desquamative gingivitis. Hyperkeratosis can be seen in case which results in leathery texture, that is mostly seen in case of drug-induced gingival enlargement. Okay, so these are the different changes in the surface texture. So normal will be stippling, loss of stippling in chronic inflammation, smooth, usually you will get a smooth surface in atrophic gingivitis, peeling of the surface you can see in desquamative gingivitis, and leathery texture you can see in drug induced gingival enlargement. So coming to the apparent position of the gingiva. So apparent position of the gingiva, the level of crust of gingival margin. So that is from the level of crust of gingival margin to the CJ, there is the visible area what we are seeing. But the severity of recession will be determined by the actual position of gingiva, not its apparent position. Okay, there are two types of recession. So there is visible and hidden. So coming to the etiological factors of recession, so what are the reasons for it? So you can see gingival recession in case of like older patients, that is with it, that is increases with age and varies after the age of 50 years. So these are the main reasons for gingival recession. As you know, faulty toothbrushing techniques. If you are having horizontal toothbrushing technique or very vigorous brushing, that is called it leads to recession. There is the gingival abrasion, cervical abrasion, or cervical abrasion. Then comes to tooth malposition can also cause the recession. There is the tooth malposition if it is crowded in area. So, but the teeth that are placed labially will be having thin bond or thin gingiva. So there are more chances to get recession. And friction from gingival soft tissues. That is, with the friction, you can cause a recession. That is called as gingival ablation. Then gingival inflammation. There is a sequelae of gingivitis to periodontitis. It can come down. The position of gingiva can come down. Then abnormal frenal attachment, frenal pull will cause gingiva recession. Then trauma from occlusion will also cause recession. So clinical significance will be, so gingival recession will be the exposed root surfaces. They are susceptible to caries. Abrasion or erosion of the cementum exposed by the cementum is exposed by the recession can cause dentinal sensitivity. So it will be the dentinal tubules will be exposed to the external environment. So there will be more sensitivity. Then it can cause hyperemia of the pulp and associated symptoms. It can result from excessive exposure of root surface. Then interproximal recession will cause oral hygiene problems in maintaining the oral hygiene maintenance, and the it will why it because it causes more plaque accumulation. So changes in the gingival contour, you can see different types of contour. So normally it will be the contour, it will be scalloped and knife edged. You can see in disease cases, you can see rolled out margins with blunt internal papilla. So scalloped and knife edged will be like this. So if it is rolled out margins with blunt internal papilla, it will be like this. So you can see some other changes like that is called a Stillman's cleft and McColl's festoon. This is seen in case of trauma from occlusion. So you can see that apostrophe shaped indentation with gingival margin. So there is Stillman's cleft. I will show you the pictures later. And McColl's festoon is the life server bulge enlargement of the margin. So there is the McColl's festoon. So this is mainly due to the trauma from occlusion, though they represent peculiar inflammatory changes of the margin. So as we said, this is the apostrophe shaped gingival margin. You can see that it is called Stillman's cleft. And you can see that this bulge, this is called as lifesaver bulge. It is called as McColl's festoon. So it is seen in case of trauma from occlusion. So coming to the summary, that is we are correlating with the clinical features and the histological features. So you can see this tabular column where we have defined there is the appearance in the health in case of color, size, shape, consistency and surface texture, and what are the changes you can see clinically, and what are the causes for the changes. You can go through it in details. So it is a continuation. There will be changes in position of gingival margin, position of junctional epithelium, mucogingival junctions, bleeding and exudate. You can go through it in details. The causes for the changes, what are the clinical appearances and the appearance in health. So that's all for today. Thank you.